Thank you for joining us for today's webinar. As you know, it's the latest in Parkinson's research and clinical trials. As Mel mentioned, my name is Dr. Soania Mathur. I'm a family physician, Parkinson's patient, and a proud member of the board of directors for the Davis-Phinney Foundation. I also have the great pleasure of being your moderator today. In today's webinar, we'll be talking a lot about clinical trials in general, the types of research that's out there, the benefits and risks of participating. We'll also explore some of the myths and misconceptions that people have about this process and how to get involved. Getting involved is really a vital topic to cover, and I'm glad we're addressing it today. You know, for a new neurologic treatment to get from the lab counter to the pharmacy shelf, it can take well over a decade and over $1 billion just to get there. And approximately half of that time is spent in clinical trials, yet close to 85% of all neurologic clinical trials are delayed somewhat by recruitment difficulties, getting participants to come join the study. And close to 30% fail to recruit anyone at all. And if you think about it, that's a really huge waste of resources and money and time that you and I don't want to waste at all. And so we'll cover that. And we'll also then delve into some of the important clinical trials that are ongoing right now and some of the interesting new treatments that are coming down the pipeline. Joining us today to help navigate this topic is Dr. Drew Kern. Dr. Kern is a movement disorder specialist, having trained at the Toronto Western Hospital. He now works at the University of Colorado and is an assistant professor in the neurology department there as well. Along with his extensive clinical work, his research interests include deep brain stimulation and alpha-synuclein in Parkinson's disease. He also has a particular interest in clinical trials. So welcome, Dr. Kern.
Thank you very much for having me part of this webinar. I appreciate it.
Oh, we're absolutely delighted that you could be here. Dr. Kern, our listeners likely have an idea of what a clinical trial is, but perhaps it would be a good idea to start off in explaining what the different types of clinical trials are, because I think most people think it's always testing a new medication, but there are different types of clinical trials, aren't there?
Yes, there are. So I think it's important to first understand that a clinical trial is developed around trying to answer whatever specific clinical question. And then based upon that question, the trial is developed. And a clinical trial can vary as far as the type, the cost, the number of patients, type of patients involved, and the number of centers that might be required to be able to recruit the number of patients for a clinical trial. In general, when we talk about a clinical trial, we think about them in the context of, is the clinical trial's main outcome to look at safety, or is it to look at efficacy? And those aren't necessarily absolute. A clinical trial, as you well know, can be a combination of both. I think it's helpful also to know that throughout the entire process, there is tight regulation on clinical trials. And as you had mentioned, there can be a significant delay in a medication coming out available to the market. And in part, that's because of the tight regulations that are required. Now, these are important because we must have a form of standardization based upon medical, making sure that the drug is safe, but also ethics. And these are independent organizations that are really out there and are required to ensure that volunteer participation is taken to the forefront rather than developing the company's medication, just as an example. When we think about clinical trials, we can break them into mainly two main categories, that being observational, and the other one that people are more maybe familiar with being interventional.
Okay.
And an observational clinical study is further broken into two main categories. One being a case control design, and the other being a cohort design. And these are observational, meaning that the researcher, herself, is not actually performing any action upon the patient or volunteer, rather seeing what potentially natural history will provide. So an example of this with the case control study is the patient develops a disease, let's say Parkinson's disease. And we have a cohort of a number of individuals with this disease in a specific region. The individual then, or the researcher will then go back and look and say, what was a potential exposure that this person may have been experience that may have transpired into developing the disease.
Mm-hmm.
And that's an example of a case control type of study. And an example one can think of is, gosh, there seems to be a lot of individuals with Parkinson's disease in this one region. This is a region high in pesticide use. Is there a risk or association here of pesticides contributing to Parkinson's disease? So that's actually done retrospectively. So they look back in time.
Do they also look at, say, the history of people in a different area that are not exposed to pesticides? Would that be part of that kind of study?
That would be another one. That's exactly right. So that's very valid point. So they take another group of individuals and can compare them to those that were not in that same type of environment, to see if there's a difference in the risk of developing the disease. And that's absolutely correct.
Right.
The other type of observational studies are those of cohort design studies. And in those type of studies, individuals may be exposed to something that they know of, and then they look either prospectively, typically, to see, do they end up developing the disease? Mm. I think it's important because we all think about clinical trials as far as a drug being provided.
Right.
But these are clinical studies that are important to do to actually understand the disease itself. And one can see that, gosh, in these type of observational clinical studies, we're not necessarily providing an intervention here, hence the risk of this is quite low, but we learn a lot from these design studies. Mm-hmm. Then if we want to go on to the other type of main category studies, those are interventional studies.
Right.
And those can be broken down into a number of different categories, for example, that the FDA even tries to organize. And those can be prevention type of studies, screening studies, genetic studies, treatment studies, diagnostic type of studies, improving understanding about individuals that may or may not have the disease, quality of life studies, and even from that, then you can think of the study as either an adaptive study or a fixed study. And what I mean by that is, in a fixed study, the trial is set up. There's no deviation from the study that's designed.
Okay.
In an adaptive study, which is a new type of way that we think about clinical trials, they do interim analysis, and based upon that analysis, they may change part way in the study, the design of the study, to be able to better answer the clinical questions that are being posed.
So I see. So that it's actually kind of, it changes with the course of the study. So if the study's going to go for 5 years, it might change midway based on what they're observing so far.
Yeah, and one could think about, as an example, a study in which was just recently completed, looking at, does drug A, which is a, let's say, levodopa that has extended release, does this actually reduce off time in Parkinson's disease?
Okay.
And unfortunately, this is a negative study. But as an example, if they did an interim analysis, the reason it was partially a negative study is that they compared it to individuals on regular levodopa who were, quote, optimized. Well, we can optimize somebody very easily if you say take levodopa every hour, as opposed to this other study drug, which is take this study drug once 3 times a day. Hence, they're optimized. They were too optimized on the control. Hence, although it did provide benefit, it was not better than the control. So if you had adaptive design, you might say, well, this isn't really answering our type of question here. You know, maybe we need to change this as far as regulations saying you can't take medication more than X number of times or X hours between dosages.
So that would make sense. It would make more sense to take that group take the levodopa as they would normally take it, as people would normally take it, which is not necessarily every hour.
Yeah,
I guess. Dr. Kern, there's also the terms our listeners hear a lot: phase 1, phase 2, phase 3 clinical trials. Could you sort of maybe go through that and describe them in a little bit of detail as well?
So those phases are done when we're talking about new drug development.
Okay.
So when we talk about that, we have four main phases. And in fact, you can even think about a phase 0. And we have phase 0, 1, 2, 3, and 4. Most everyone is going to be more familiar with the phases 2 and 3.
Mm-hmm.
So, but let's cover the other ones because it's an important question. So in a phase 0 trial, this will be involving a total maybe like 10 patients, very small study. And what we're looking at is the pharmacokinetics and pharmacodynamics of the drug. And this might be, for example, in healthy controls, healthy normal individuals. And pharmacokinetics means what does your body do to the drug itself?
Right.
Do you clear the drug? Do you pee it out? Does it get metabolized by the liver?
Right.
How does it pass through the system? And pharmacodynamics means what does your drug do to the body?
Mm-hmm.
So a really nice example of that is, does this drug actually clear out alpha-synuclein, and do we see a increase, let's say, in alpha-synuclein in the CSF, i.e. you're clearing it out with this drug?
Okay.
That's really a phase 0 study. And that's a very small study. In a phase 1, we start to really, the main purpose of that is to look at safety. And in these studies have maybe about the same number of patients, maybe a little bit more, not many. And there is a lot of time that's invested, as one can imagine, because we're looking at anything and everything that potentially could be a risk.
Right.
With that being said, they already know what potentially are the risks of the drug because there's been a lot of animal studies and primate studies potentially that have already been performed to identify the risks that could be associated with this drug in people.
Right. And then the next phases are?
Phase 2.
Yeah.
Phase 2 study, it's a larger group of individuals. And in this study design, we already know a lot about the safety. They've picked out, based upon the phase 1 study, the dose of the medication that they think should be prescribed, or dosages. And we're really looking at a phase 2 as far as efficacy. So we're trying to see, do we see? And we're continuing to collect information about drug safety as well.
Okay.
Then we get to a phase 3. And in phase 3, people think about the randomized controls studies.
Right.
Those are large studies, thousands of people, let's say, or hundreds of people, multi-center to be able to recruit this number of patients. And one can imagine, wow, that's going to take a lot of time to recruit that number of patients. And you can only have so many patients involved in the study at a site per time, given the amount of work that is required. And those studies are usually comparing the treatment arm to a control arm.
Okay.
That control arm could either be the drug in a lower dose, for example, itself, so comparing the treatment to a controlled dose of the drug itself, or comparing the treatment arm to a gold standard treatment, using the analogy that I did before of immediate release carbidopa compared with a longer acting carbidopa, levodopa, or comparing this with a placebo, which is, as most people are aware of, a medication that doesn't actually have any active drug in it, and the patient and usually the provider is blinded as to that treatment. After that, the drug companies usually will then submit to the FDA, and let's say that the FDA approves it. Then we can have a phase 4 study, and that's post-marketing research. So that's when, gosh, this is a brand new medication, and the FDA is requiring the physician to fill out any forms or identification of adverse effects or clinical benefits that is ongoing with this medication.
Right, so it's follow-up.
Yep,
Yeah.
exactly, exactly.
So, I mean, Dr. Kern, there are probably a number of issues that make enrolling in a clinical study that much more difficult for people. Everything, many of which are actually logistical. Accessibility might be an issue. Sometimes they don't meet the study criteria. More significantly, there's like a lack of knowledge and a number of myths and misconceptions about clinical trials that may influence a participant's decision whether or not to participate. So that maybe we could go through them, and that might give our listeners an opportunity to learn more about the clinical trial process in that. So the first one, I think you sort of almost answered, and that's, I hear often that people say they don't want to be a test subject for brand new unproven medication that they know nothing about, that's too dangerous for them and risky. But I guess there are other types that they can get involved in, as you mentioned, the observational, and you also mentioned that they know about the safety and efficacy before they get to those phase one, or they learn about it in phase one, but phase 2 and 3 studies are usually they're quite familiar with it. Is there anything you want to add to that in a patient that's worried about risk?
Well, one point I would say is for any potential volunteer, there is a clinical study available.
Right.
For example, on clinicaltrials.gov, before this webinar, I looked, there are 2,421 clinical studies out there. I mean, that's really exciting. And the fact that we've got all these wonderful studies, specifically in Parkinson's disease, that someone could peruse and see what might work for her or him. And as you said, there are ones that have very low risk, like an observational study that would have a very, very low risk. There's ones that are like a phase 3 study, in which, gosh, there's already been a number of individuals that have already gone through this portion of the study. They're knowledgeable about it. And yes, these are actually the risks that they can tell me about. And then there's phase 1, on the contrary, where we're really just learning about this medication.
Right.
Now, the point about the risk is anytime the risk is higher, those regulation bodies that I mentioned require a certain amount of continued follow-up.
Right.
In a phase 1 study, it's not uncommon that an individual, for example, will be hospitalized even for a period of days when starting the medication, so that they have that ongoing nursing care support to evaluate if everything's going okay. You'll have the physician on call, and that's very common for me. I'll get a call, for example, late in the evening to be able to address and raise any concerns that the patient might have. So a lot of investment from the medical care community to ensure an individual's safety if she or he volunteers in a more, let's say, phase 1, phase 2 type of clinical study.
Right.
Point out about those risks, that's a really key point. And I think as you can allude to, that's really a key factor when you talk about the informed consent process.
Absolutely. And we'll hopefully get to that as well. The other thing I've heard is patients say that if I participate in a clinical trial, then I might get worse. I'm sort of on my meds now, I'm feeling okay, or I'm early in my disease and not really requiring much. But if I go into this clinical trial, then is there a risk I might get worse?
Yeah. So I think of clinical trials as just another weapon in my box to fight this disease.
Mm-hmm.
Let's say I have a patient that, despite all my best efforts, he has 3 hours of off time throughout the day. And I could make her on, but then she's got horrific dyskinesias or some other adverse effect. Maybe there's nothing I have really that's great with regards to the medications that are currently available, unless I would consider maybe a surgical intervention. But there may be, for example, a clinical trial that I can enroll the patient in that's a treatment as well, and will get us to the goals for this patient, as an example, where we can reduce that amount of off time that I simply would not have available with the commercial drugs that we currently have. So although you can think about I don't get the same amount of care, in actuality, you may have a lot of other advantages, benefits with regards to going into a clinical trial if it's used for a clinical treatment. And there's a lot of follow-up. That's, as you know, as we've already said, involved in clinical trial. You're seeing your doctor at scheduled times, but say it's once a week or once every other week.
Right.
It may be very hard for a patient to get in to see their movement disorder neurologist that frequent.
And I think that ties into another myth that we hear often, that if I join a clinical study, I won't be able to drop out without jeopardizing my treatment. But if you're saying that they're going to evaluate you on an ongoing basis, there is an opportunity for, if you are, for some reason getting worse, that they could do something about that.
Yeah, that's exactly right. I mean, the amount of data that's collected during an evaluation exam process in a clinical study is immense. And there isn't a timeline like we have maybe in the clinic of X number of minutes you have per patient before the next patient you need to see. That's not really what's going on in the clinical study. It's, we have to complete this amount of work, and every single time you're required to basically ask about how are you doing, adverse effects, any problems whatsoever, and sit there and answer any and all questions that the patient volunteer has.
Right. Another myth I hear, or misconception, is participating in a clinical trial is bound to disrupt my daily life, that it's going to be a huge time commitment. And people have, especially those of us with young onset Parkinson's, have, sometimes regular jobs or young families that need carting around and just don't have the time for it. How would you address that?
I would say that's exactly, you're exactly right in that question and your follow-up comments. That is very, very true. When you're getting involved in a clinical study, one of the questions that needs to be posed is, what is my time commitment for this study? You really are, well, anyone participating, they're a participant, an active, involved member of these clinical studies. They wouldn't exist without them. Mm-hmm. And if you say, well, I can only invest so much time and then maybe I'll drop out, that's not really going to be good for the clinical study, for the development of medication, and for the Parkinson's disease community as a whole. So looking at and saying, how many visits does this involve? And I've had patients say, this time of the year is really bad for me. I've got my kids, they're in school, we've got this activity, we've got hockey going on for this time period. Maybe I could do this in 4 or 5 months, for example.
Right.
This would work better in my schedule. That is perfect, because they're already thinking about, how can I make these appointments? How can I invest the time and effort in filling out, for example, surveys if that's being required? Or, hey, we go on these large family vacations at this time of the year. I'm not going to be able to do this type of time commitment. With that being said, and thinking about studies, there are clinical studies that might be a one-time visit or a two-time visit. Come on in, for example, we're going to put this watch on you and you're going to carry out your daily activities. Thereafter, come back in a week and we're just going to take the watch off and download and ask you a few questions. Right. You might say, well, I'm really active and busy, but I can actually do that and participate in a study that's designed like that. So that's what I mean by, there typically is a study for everyone, but thinking about the time commitment and the investment is something that's absolutely essential to think about. Yes, you're right.
And geographical location. I've had people say that they can only participate in a trial if they feel if they have access to a major medical institution. Yeah. And sort of addressing that would be great. And also, if that's not the case, where can a patient access information about clinical trials that they can participate in based on their geography?
So there are a number of good resources to look for finding all these clinical studies. I already mentioned one of them, which is clinicaltrials.gov, which any clinical study is required to actually be listed on there. And if anyone was to go to that site, they can see, is it active? Is it recruiting? Is it completed? Get a synopsis about it. And where are the sites that are running the study? You can also do a search based upon region to find out what are the studies that are being done where one lives. Other resources, as you mentioned, academic institutions often will always have clinical studies. But in addition, most physicians, I know especially including neurologists, they're up to date about what clinical studies are ongoing. We all typically attend the American Academy of Neurology, and that's when we learn about a lot of these clinical studies. And so your own doctor is a great resource to ask about what clinical studies might have qualified that you're aware of within the region. Now, some, as you know, because they have a hard time in recruiting sometimes patients, or they have such a high number, they will have transportation provided for patients to go from their location out to another location. So,
Right.
for example, I've had patients fly in for a clinical study that I'm running. And
Right.
so that's not uncommon either. Of course, all those expenses are paid for by the sponsor, not by the volunteer at this point.
Well, that really brings up a really interesting question about the sort of the value added to patients who do participate, and what the research community is trying to do in order to accommodate patients' needs and requirements, and sort of make it, I guess, the altruistic reason is always there to participate, but to make it a little bit more easily for patients to participate.
Yeah.
Can you think of anything else other than the transportation that you have seen develop in the field?
Yeah, so for example, patients that participate in a number of clinical studies that we have ongoing, if they live a little further away, you can think about coming across the mountain range in the winter time, the sponsor will have them stay in a hotel, and the hotel is right across the street, and also pay for the transportation from the hotel to here. They'll pay for meal vouchers because they don't want you to necessarily have to pay. And sometimes there can be a compensation for the volunteer's time, but that depends upon study to study.
Right. So it depends on which study you're going for. Are there other added values, like do patients have access to the results sooner than other people, or if they're on a drug that seems to be working, do they have access to continue on that experimental drug?
Yep. So it's a great question. So one point that's often raised is, and I'll expand upon that. So if you have a clinical study, and let's say I get placebo, and I hear patients say, I don't want the placebo, and we can talk about that. But then they often go, but if I get the placebo, can I eventually get the study drug? And most studies will have that as an open label extension period. So after the completion of that study, if they think that, for example, the medication is safe so far and is of benefit, then they'll open that up to say, well, you were put on the placebo, but we're going to give you the active drug now as an open label extension. Now, obviously, the other individual who is on the active drug, let's say, and they're doing fantastic with it, and they want to stay on this, they can continue as an open label extension. That's an important question to ask during the informed consent process is to say, is there an open label extension for this study? And as a PI, I will always ask that of a company. And if there isn't, then that makes me a little bit concerned, because that's going to maybe be a harder study to recruit for. If I say, hey, this is a 12-month study, but there's no open label extension, that's going to leave possibly my patients high and dry. So most companies, sponsors do not do that. As we've already mentioned, the other benefits, you get continuous care, adjustments to medication, safety monitoring as well. The cost of the medication is free, including typically always in an open label extension, just as an example.
Excellent. I guess we might want to go on now to more of what research is out there. I mean, I think you gave us a really great idea of the benefits of participating and the types of studies that we can participate in, but what's sort of on the current research landscape? I mean, as you mentioned, over 2,000 studies, I think you said, on clinicaltrials.gov. I mean, that's exciting. It's fairly robust. But maybe we should look at what's on the horizon for new treatments. I mean, one thing I do notice is that it's changing. I mean, 20 years ago when I was diagnosed, we really would be talking more about dopamine replacement and finding new ways to do that. But now we're sort of looking at studies that are targeting the pathology of the disease itself, what's causing Parkinson's in the first place. So could you maybe, I guess the so-called disease-modifying therapies, can we talk a little bit about that?
Yeah. So one point to bring up is improved screening of Parkinson's disease. by the time an individual, as you know, has Parkinson's disease, they've lost about 80% of the neurons that produce dopamine. And so if you develop a disease-modifying treatment, even if it is absolutely amazing, they've already lost a lot of those neurons. They've already developed symptoms. They've already noticed something. And so what we've been focusing on in the more recent past is looking at, can we improve our ability to diagnose this disease? And in fact, can we diagnose this disease even before the onset of the motor symptoms? I mean, imagine if you were 20 years, 30 years of age, you've got a strong family history, and you could find out, yes, you do have the disease. And you say, well, I don't even notice I've got any symptoms. You say, well, you probably won't notice that you have symptoms until you're 50. Right. However, we've got this medication that will slow the disease down so that you may never develop any symptoms whatsoever. I mean, that's the hope of what we'll get to. And so when we think about the clinical studies, I like to kind of break it up into screening or identification, biomarkers. Next, think about the ones that are potentially disease modifying. And then we have symptomatic treatment, and then thereafter, interventional clinical studies. A nice way of thinking about it in the context about the disease progression.
Okay.
And if we think about the screening ones or identification of biomarkers, there's been a lot of work that has been done on this. We were participating in clinical studies looking at, for example, colon biopsies. And as you know, about 4, 5, 6 years ago, that was a really hot topic. You could diagnose Parkinson's disease by having a colon biopsy. I'm also and continue to be involved in skin biopsy research. So just a small skin biopsy that can be done in the clinic can actually identify Parkinson's disease. And the studies that we've identified in collaboration with colleagues is that it appears that that may be a possibility in distinguishing Parkinson's disease from, for example, multiple system atrophy, an atypical form of Parkinson's disease. There's also work ongoing about artificial intelligence, and that perhaps artificial intelligence can recognize patterns, and with those patterns develop a model to predict an individual is going to be at risk. For example, gait analysis, do they have REM behavior, smoking history, family history, age of their onset, their sex, and maybe that can be better able to identify individuals that may be at risk for developing the disease. Then I think it's helpful to talk about genetics. And genetics has come a huge, huge way in our recent past. And in fact, now genetics is commonly, and I always do, talk about it, especially in my young onset Parkinson's disease patients. And in part because genetic testing has actually become quite more reasonable to be done, and in some situations is even covered by insurance. And that's helpful because if we actually understand about the genetics, the causes of the individual developing the Parkinson's disease, and there are many different ways of developing Parkinson's disease, as we know, then maybe we can develop medications or treatments specific to that genetic mutation that that individual has. I mean, that's pretty novel. That's like saying you have this type of Parkinson's disease, and let's say you are Parkinson's disease LRRK2 positive, you have a LRRK2 mutation, and we now have a medication specific for LRRK2. That's very personalized medicine.
Right.
Hope that we'll get to that point. So that's kind of the screening. And as you mentioned, the disease modifying treatments.
Right.
This is...
Sorry, just one quick question. I guess when you talk about that sort of specific LRRK2, for example, target, how, because that's a small percentage of Parkinson's patients that have a LRRK2 mutation, for instance. How does that generalize to the broader patient community? How will that help us all?
So there are many different causes of Parkinson's disease, and LRRK2 is thought to be involved in the lysosomal, which is an organelle within a cell involved in cleaning up the functions of the cell so that it doesn't actually die. It appears that even individuals that have, we would say, sporadic form of Parkinson's disease have an impairment in the lysosomal function.
Okay.
And as an example, there is a LRRK2 inhibitors that are being developed. And LRRK2 is mutation causes an increase of this enzyme to be developed that actually causes cell death. And so this inhibitor shuts that down. And the potential is that that will preserve the cell and preserve the lysosome. Interesting enough, in these studies, it looks like even in sporadic forms of Parkinson's disease, it also is beneficial. So that is actually exciting in that, yes, patients maybe with LRRK2 might have the greatest benefit, but that doesn't mean that other individuals that develop Parkinson's disease for other reasons also wouldn't have notable benefit.
Okay.
That's one example of a disease-modifying treatment. If we look, for example, at GBA, which is another mutation that can cause Parkinson's disease, and that's on the opposite, where you don't have a good function of the lysosome because of this mutation. There are ongoing studies looking at, can we improve by giving either a medication, which is in clinical trial, or can we actually give back the gene to actually improve the function that this gene normally would do, which is to allow for the lysosome to function correctly. That alone could also be beneficial, not just in GBA patients or individuals with GBA mutation, I should say, but also in individuals with sporadic forms of Parkinson's disease. So that's how we can actually really learn, as you said correctly, about, gosh, this appears to be, yes, much more impaired because you have this gene, this function of the cell is much more impaired, but gosh, this function of the cells also appears to be impaired in sporadic forms of Parkinson's disease as well.
So we talk about, I guess, gene therapy in some ways. How does that differ? You're talking about genetic mutations. Where does gene therapy come into play?
So gene therapy can come into play as far as a disease-modifying treatment. For example, like we just mentioned, replacing a gene or shutting a gene down. And there's ongoing work looking at this, such as removal. People have heard the word CRISPR, for example, removal of an abnormal gene, for example. Could that be done? People have heard about ASOs, which are anti-synuclein oligomers that actually can prevent the continued messaging of a gene to be produced through the protein. So these are ongoing research studies that have a lot of hope. But then there's also other forms of gene studies that are looking at trying to restore the normal function. And one of the interventional studies that is ongoing is looking at alpha aromatic decarboxylase, AADC. AADC is an enzyme that's involved in converting levodopa into dopamine. And in Parkinson's disease, fortunately, there is a loss of AADC within the putamen of the brain. Consequently, individuals need to take a lot more levodopa, and even when they do have levodopa in the brain, it doesn't last as long. And this study, for example, is delivering AADC. It's a surgical study, so they're delivering it into the brain as a one-time basis with a vector that then implements into the genes itself in the putamen and allows then naturally for levodopa to be converted into dopamine. That's in clinical study right now, and the results look fairly promising. Whereas you can imagine individuals can have a reduction of the dose of medication they need to take because it lasts longer, improved on time, and potentially even reducing dyskinesias because they no longer have these high highs and low lows. They have more of a continuous amount.
And how far along are we in this field? How close are we to getting something like that?
Well, that's in clinical study right now. So that the hope, that's been now, it's the third portion of this type of study. And that's in a phase 2 study. Recruitment for the study is very, very challenging. And I can tell you for this one particular study, as an example of how hard it is the FDA has required about 100 patients or so to be recruited for this type of study. Very hard to recruit for a surgical study in individuals. And they can expand out to as many centers and sites as possible, but recruitment can be quite low. So I would say it really all depends upon being able to have volunteers to participate or be interested in learning first about these type of studies and considering it with their provider if it's an appropriate treatment for him or her. These studies are ongoing. Hopefully they'll continue to ongo. And how far off are we? Well, this type of study might be, we've already had promising results, so such a study might be a few years down the road from where we are now. The other studies, the other gene studies that I mentioned, these are more in phase 1 studies. Then they go on to phase 2 and 3, as we mentioned. So those are several years off. But it's hoped that these will continue to come along and help us develop disease-modifying treatments. And that totally changes our entire field of how we would treat this disease and even how we would discuss this disease with our patients.
Right.
As you know, somebody would say, look, you can start the symptomatic treatment. It's going to help you with the symptoms. It's not going to do anything for the disease itself. If you're interested, we can do this. If you want to wait and think about it, perfectly fine. Now, all of a sudden, if I actually have something that stops or slows the disease down, that changes my whole conversation. All of a sudden, I'm talking about this almost much more like it's an antibiotic and saying, look, we need to start this. We need to start this now. I know you don't want to, but I can tell you, you're going to be much happier down the road compared with if we delay treatment.
Yes, I mean, yeah, it would be a big game changer for sure, especially if somebody doesn't have to embark on this journey in the first place. But you mentioned symptomatic treatments, and that's something else that can help us maintain our quality of life now or improve our quality of life now. Can we maybe explore that a little bit?
Yeah. So there are ongoing clinical studies looking at carbidopa, levodopa continues to be our best medication. However, it has the highs and the lows, especially as people take it for a prolonged period of time with the progression of the disease. So are there ways of developing this medication where it's provided more continuously or that you don't have to take it as frequent? Those are ongoing clinical studies. So a delayed release, a true delayed release, such as think about like an M&M, and that the outer coating dissolves, then the middle coating, then the inner coating gradually over a period of time. And so you only have to take the medication maybe every 3 times a day or 4 times a day. Those are ongoing studies. There are also studies looking at the other symptoms associated with Parkinson's disease, for example, dyskinesias. And there's a novel medication that's out there, which is it's a sigma-1 receptor, and that's a novel medication all by itself. And it appears that this type of medication at lower dosages affects the sigma-1 receptor. However, at higher dosages, this medication appears to act upon D3 receptors as well as on serotonin receptors, and may, not only in the fact that it has the sigma-1 receptor effects, that may be neuroprotective by itself, but at the higher dosages may also have anti-dyskinetic effects. So that's also in clinical study right now, which is exciting in the aspect that we might have something else for dyskinesias than what's available on the market, which everyone knows is unfortunately quite more limited. So
Right.
symptomatic treatments. And that kind of segues into intervention. So there are ongoing clinical studies looking at, for example, delivering levodopa in a more continuous way, as I mentioned, and there's oral ways, but also subcutaneous ways, where an individual wears something very similar to an insulin pump, which is has a small tube that goes just under the skin and continuously releases levodopa, carbidopa throughout the entire day and even throughout the night. And I think that's something I'm really excited about. Is Parkinson's disease is a 24-hour disease. And unless you're waking up in the middle of the night to take your medication, which unfortunately some of our patients end up doing, it would be nice if they could actually take something continuously throughout the entire 24 hours and even improve their sleep. Thereby, an improvement of sleep will improve their motor symptoms and even reduce fatigue. That's well known. So this is an ongoing clinical study where it's a subcutaneous continuous infusion of carbidopa, levodopa, and as I think many of the individuals on the webinar have mentioned and have probably even participated in, there are 2 ongoing companies that are looking at this treatment option. The 2 companies have different formulations of carbidopa, levodopa, so they're actually they're actually quite different in that context.
You also mentioned that, I mean, most of what we were talking about is directed towards motor symptoms, but non-motor symptoms really do affect quality of life for patients. Are there any treatments that are on the horizon for non-motor symptoms, such as, I mean, I think one came out for drooling recently, psychosis, those sorts of things. Is there anything that's exciting to you that's on the horizon?
So drooling, as you mentioned, was one treatment that came out recently and was found to be very favorable. And that was a form of botulinum toxin injection. And that was very effective. And that's quite exciting. And we had known that botulinum toxin injection had benefit for our patients, but it was nice to see an actual clinical study demonstrate this.
Right.
In addition, they demonstrated the actual dosages that the patients ended up using, which was anywhere from 75 to 100 units, noting significant benefit without causing excessive dry mouth with this.
Right.
And then with regards to hallucinations or psychosis, there are ongoing studies looking at this, and we had a recent medication come to fruition from these studies, looking at a novel mechanism and that novel serotonin receptor that potentially in itself could be beneficial in developing future studies, looking at can we develop an even better drug knowing that these are effective. That leads to one other question that I know a number of individuals might have, which was what about cannabis? Because that's in Colorado, you can't talk at least once a day without talking about cannabis. And I know the same is probably in Ontario.
Mm-hmm.
And we have THC and cannabinoid receptors in our brains. However, it's not quite clear as to what they actually do. And this is actually kind of the converse. It's an interesting discussion all by itself, in that it's the patients that have been really driving the research rather than, unfortunately, I think the researcher is driving the research and actually developing the studies to actually know. So our patients teach us a lot, and they've taught us anecdotally, at least my patients, that CBD appears, for example, to help sleep.
Right.
I take this and I'm able to sleep. It helps me, for example, with restless leg syndrome. I rub this on my legs and it appears that I am much better with the quality of sleep. You've given me all these benzodiazepines, you've given me melatonin, you've tried adjusting the cinnamon, all these things, and maybe even a sleeping pill, but it's not as effective compared with this little bit of CBD that I take.
Right.
So that's one thing that's exciting that we're actually ongoing looking at. Now, the problem, of course, as everyone knows, is obtaining funding for doing CBD research or cannabis research is very limited. Hence, there's no research investment into this, and hence our patients are having to go all on their own to actually learn about this medication. I've had patients tell me that it appears also to help with tremor, and it appears to help with dyskinesias. Of course,
Right.
we don't know what dosage, and we don't know if it's more THC or if it's more CBD. obviously are looking more at the CBD, given the concerns of THC contributing to more psychosis and hallucinations.
Right.
So that's an ongoing clinical research study that we're actually performing here, and there's tight drug safety regulations on that as well. And that finally now our state actually has funded these type of research studies.
Yeah, that's always a hot topic. There's one question from one of our listeners who's asking about what's new in DBS in terms of latest research.
So in DBS world, it used to be that there was only one company developing that had DBS. They had a market on DBS, and they did a very good job. But now there are two other companies that have come out with their own products. And that's driven new development in DBS. And that's also driven the other company to really expand their research and development. And within DBS, what we currently have are, for example, directional leads, where I can steer the current to areas that I want to steer it to and avoid areas that I don't want to have it delivered to. Mm-hmm. There's also ways of dividing up the amount of stimulation between different contacts. And an electrode either contains 4 contacts or up to 8 contacts. And I can use any combinations to stimulate through any of those. Now we're also having a lot of ones that are looking at, are there biomarkers, signatures within the brain, signals within the brain that tell us that a certain contact might be better to use compared with other contacts. And the one that everyone can think about is that called beta activity. High beta activity goes away when you take levodopa, as an example, goes really high in the context of you having freezing and you can't move. So levodopa reduces that beta activity. Well, if you have an electrode, let's say, that can not only stimulate, but also it can record directly that high beta activity. And let's get a little bit more futuristic, but probably not that far off here, thinking about the next couple of years. Based upon receiving that high beta activity, can then automatically deliver a set amount of stimulation to block that pathological activity. You would have something that we would call a closed loop system, where the battery, or in this case, the DBS system, is modulating the amount of stimulation that is being delivered based upon your own brain's telling the DBS when and what to do and when to stimulate. And that's not futuristic. There are a lot of ongoing studies that have already documented, and we know about these signals. And we're using these signals, at least here, to identify if we are in the right position, right place when we put an electrode in an individual's brain. And we will modify that based upon knowing about the high amount of beta activity that we're recording intraoperative.
It's an exciting time, really exciting time. And obviously would not be at that point if we didn't have people participating in those studies. So as we sort of our time comes to an end, I have one last question to ask of you. For someone who's considering participating in a clinical study, what are sort of the most important questions for them to ask during their decision-making process?
I think one point is, I can't stress enough that during the informed consent process, this is really informed consent. This isn't a time where you just look at the paper, say, okay, fine, I trust you, and let me sign it away. And in fact, if I have a participant doing that, I pause and I get a little bit concerned about them participating. We want to have very educated participants, ones that can actually document and tell us what they're feeling, how they're feeling, and complete the required documentation that we need to actually know about the outcomes. So that's really a time. And the questions to ask are, what do we know about this? Let's use a drug as an example, because it's easier. what do we know about this drug? What does the animal literature show about this drug? What do you know about the risks of this drug? What are the potential benefits that I could have with this medication? Does this meet maybe a treatment goal, for example, if you're considering that? What is the time commitment? How am I going to get here? And then another question that we often forget about is, if a problem occurs, who's going to help me? Who's going to take care of me? Where do I go? Who's going to pay for this adverse event or problem? Is the sponsor going to cover it? Is the academic institution going to cover it? Is my insurance going to cover it? These are all important questions to kind of answer or ask in this process. And then, as we already mentioned, what happens if this really works and I really like it and I want to continue on with the study? Can I do so? It's important to know that any time a volunteer goes into a study, they can drop out at any time. It's completely voluntary. You go in, I can't make this time commitment, I just don't like it, you can drop out. So at any time period, it's completely voluntary. A participant can leave the study. Those are some of the basics that I can think of. And you shouldn't feel pressured, anyone should feel pressured to going into a clinical study. It's more the contrary. You should feel, gosh, this really sounds exciting. I'm interested in this, and this will also help me and help out, the Society of Parkinson's Disease in general. This sounds really great. I'm excited to go into the study. Those are the participants that I'm really, it just gives me a great thrill during the day to work with. It's really an enjoyable experience when you have somebody like that.
That's excellent. Thank you so much, Dr. Kern, for your time and expertise. And thank you to everyone who's joining us today. I hope that you found your time both educational and helpful. And remember, without enough volunteers to participate in medical research, we're not going to be able to find better treatments or that cure. So support research in whatever way you can, find whatever works for you, participating in some way, knowing that you're making a difference, not only for your own future, but for that of the broader Parkinson's community. It's really empowering. So thanks once again. Be well, and hope you'll join us for our next webinar on cognition. I believe it's October 30th, but you can log on to the website to find out. Thanks again. Bye-bye.
Thank you, everyone.